Imagine your next patient encounter where it's you and the patient without a keyboard. In fact, we can eliminate the keyboard altogether in the entire department. So it's you and the patient in the exam room. You can walk in and say, what was the hemoglobin this morning? What was the hemoglobin for the last 5 days or 6 months ago? When was the last colonoscopy? Who was the colonoscopist, right? I mean, this is at your fingertips. It's no different than saying Starbucks near me. It's that simple, no keyboards. In fact, you don't even need a scribe. So do you feel like this is in existence, in practice, or is this just some science fiction movie? What do you think? How many of you have something like this or know something like this that's implemented and functional? Anybody? Yeah, a few. It's real, it's happening. And what I look at this is that it's a gift of time. Like having these kind of technologies embedded into our workflow, it's really capturing 1 or 2 hours a day for that clinician, that nurse, that doesn't have to go home and finish up the charts. We spend 60, 70% of our time in clerical work, right? And this is what it's allowing us to do. So, I'm very jealous of the students, nursing students, nurse practitioner students, medical students going into school today, because I feel like they're entering the medical career at the right stage, because this is where we're going to go back to that patient-doctor relationship that we had 50 years ago. It's really reverting back, which is amazing, very impressive. So Mayo Clinic today, when they have patients coming in at night, you have the residents, doctor seeing the patients overnight, and they present next morning about the most complicated or unique case. In the past, I don't know, some of the docs in here can vouch for this, we used to spend hours in the library, physical library, looking up articles, Xeroxing the articles, getting 20, 30 copies to give it out at morning report. Well, now these guys are what they're doing, of course, they embed thousands of pages of the medical records that the patient came with. Because, Mayo is a tertiary care. They come from other remote hospitals, and they come with a bag full of medical records digitally. So how do you sieve through that digital records? 2,000, 3,000 pages of all the places they've been in the last 5 years. Now they're coming to Mayo Clinic for a solution, an answer they're seeking. So you take those thousands of pages, AI will generate a complete analysis of that. So you take those 3,000 pages, EKGs, photographs, all embedded, and ask questions. Just ask questions. It'll be part of the medical records now. So you can walk in that patient's room and just say, what was it 5 years ago? What did they do? Boom, here's an answer. In fact, the articles that are being published, right now there's no shortage of data, right? I mean, you can Google anything and get thousands of articles. The key thing is, how do you sieve through those thousands of articles that's pertinent to that patient care? AI can do that. AI can say, based on this patient who presented with pancreatitis, based on the uniqueness, not alcoholic, no stones, not diabetic, why is the patient having pancreatitis? Is it lipids? Is it something else? AI can actually find those articles and say, these 3 articles are relevant to your patient. Forget the 1,000. I mean, this is at the fingertips. It's amazing. Growing up, I was always told, I'm sure most of you, laser focus, right? Our parents always said laser. We tell our kids right now, laser focus. But here, I want you to not laser focus and focus on the big picture. Look at what the big picture is. Is the technology available to you that you can improve your systems at home or at your home facility? Can you improve the systems, run it lean? Can you improve safety? If you do these 2 things, the technology that you embed into your system, you ultimately decrease medical errors, right? Think about it. If you have optimal systems, you have increased safety, you indirectly will be decreasing the medical errors. So this is a patient of mine, 61-year-old, comes in with shortness of breath. It's 6 a.m. at the end of my shift, and literally the patient rolls in. EMS brings her in, lights and sirens, shortness of breath, COPD, she's a smoker, she uses home oxygen, and the EMS said, hey, she was hypoxic, we gave her a breathing treatment, and that was the story I got. So I examined her, she's hypoxic, yeah, they gave her breathing treatment, do I want to give another one? She wasn't wheezing. And then we disrobe her and realized her entire left leg is swollen from groin to the ankle. I mean, twice the size as the other side. So even my security guard across the room is telling me this is probably a PE, right? So of course, we run her to the CAT scan, and my decision was, do I do heparin, IV, or do I do Lovenox? What do I do, right? That was my decision point. And she's sick. She's hypoxic, she's hypotensive, and it's because of some suspicion I have is PE. So, of course, the CT's done like literally right away, 6 in the morning, we're not that busy. I'm an ER doc. I can read CTs, maybe 80% accuracy, but you don't want me to give you thrombolytics or some drugs based on my read. Okay, I want a read. So basically, we need to get that wet read or the Nighthawk read or whoever's reading that CT. So I'm like, okay, I'm waiting for the guys to read this. So I get this banner on the screen that says suspect PE. I sent the patient to the radiologist suite because I was thinking it's a PE. They simply say suspect PE. It doesn't do me any good, right? So now the thing is, okay, why would anybody put that in there? But then I sort of cursed my mouse around a little bit and look at the left-hand side. Slide 117 of 317, it says to me, that's where the PE is. So now my 80% accuracy rate just went to 99. Right? I suddenly became an Einstein because now I have the technology telling me that, hey, there's a PE on this slice, 117. It actually told me where to look. Impressive. And I'm thinking, wow, this is pretty neat. I got this report. So I go back into the room saying, let's give her, and the patient's not there. So where's the patient right now? Literally, I go run into the patient's room, where's the patient? In the CAT scanner, still in the CAT scanner. So I got the read before the patient made it back to the room. That's super impressive. And of course, this is AI generated report. And if I were to tell you that the AI generated report is as accurate or even more accurate than a radiology read, would you now go ahead and treat this patient based on this information? I did. And so my decision before this was what? Do I do Lovenox? Do I do IV heparin? Do I call the critical care doc? Do I call a interventional radiologist to do a thrombectomy? I have no idea, but now I know what to do next, right? So this information is really actionable, reliable, it's at bedside, and I can actually triage that patient now. It's bedside point of care. So when I say point of care, bedside, it's really, if you look at this and say the AccuCheck 50 years ago, right? 1974, the AccuCheck came out. Amazing. Now, obviously, you can buy them anywhere. And it's point of care. Why was the blood sugar important at bedside? We all know. It's sort of reliable, relatively accurate, it's precise, it's bedside, available, it's quick. You can act on it. This is the same thing, no different. So if I were to say, this technology is 2 summers ago, this is going to be second year now, this has been out. It's been out even longer, but it's probably gotten 10 times better today. So what I just illustrated was an actual patient of mine 2 years ago. Now the question is, the radiologist that you have at your facility, at our facility, instead of waking them up at 2 in the morning and have that read, I can save that phone call, not wake them up, let them come at the normal time at 8 o'clock and do a procedure, interventional radiology, rather than, because first of all, there's shortage of radiologists. It's hard to find. If we can save their time, put value where it belongs, we can retain these radiologists. Mass General has over 55 algorithms that they're embedding into their system and vetting them out for reliant efficiency, reliability, accuracy. Every couple of months, you have one of these protocol algorithms being pushed out into the industry. That's just one of them. Imagine 55, or maybe out of 55, only half of them will make it. That's a lot of halves, right? More than what we could say. And if we were to take a high reliability organization on this side, and then take the patient safety culture on this side and blend it together, what happens? Something very magical happens. We start minimizing medical errors. We actually make an impact on the medical errors and near misses just because we have a more efficient, reliable system. Do you think the CAT scan read for the PE was safe, reliable, decreased patient error? My error to say, I think it's this, give him Lovenox and find out I should have not, right? I mean, it's really patient safety and it's so efficient. Think about it. Patient was in the CAT scan when I got the results. I mean, that's efficiency 101. So high reliability, patient safety, put it together, minimize medical errors. So this is a Netflix series. Our neighbors are watching this. We need to know what they're watching because they're interpreting healthcare this way.
She got pneumonia, and 5 days later, she was dead. She was 38 years old.
I'm so sorry.
This happens all the time, Devin. Medical error is the third leading cause of death in the United States after cancer and heart disease. They don't want us talking about that.
But you still show up here every day.
Because it's personal to me. And there's still plenty of good doctors and nurses trying to do the right thing. I'm just trying to be one of them.
Third leading cause of death in the United States. This is season 1, episode 1, in the first 10 minutes. This is what our neighbors are watching. What's unfortunate is the medical students going into school today, they don't realize, I mean, if we know the problem, we can fix it, right? That's what I look at. And so why is it that we don't talk about this? I don't want to talk about this outside of this room, right? It's not something I would brag about. But why is it no longer news? If this aircraft skidded on O'Hare Airport today with 0 casualty, it'll be headline news on CNN tonight. And FAA needs to do a root cause analysis and make policy changes within a certain time period based on what happened and why it happened to prevent it from happening again, right? It's kind of makes sense, but it's unfortunate. We get our news or new information from the media. And the media, this is not news, this is old information. Third leading cause of death, what does that mean in numbers? It's third leading cause of death. Was it 1,000, 2,000, 10,000, 100,000? So really, it's 2.5 jumbo jet 747 fully loaded and crashing into the Atlantic every night. That's what that number is, third leading the number of patients. So the numbers are high, no matter what. What percentage do you think is a system failure? If there's an error, if there's 100 errors, we dissect them out with root cause analysis, what percentage will be system errors?
85.
Bingo. So knowing this, it goes back to say, every time there's an error, we get blamed, but we gotta fix the system. If we fix the system, we can make a big impact. So this followed about in 2015, Institute of Medicine basically said that it's likely that every person who's a consumer of healthcare, let's say we are all consumers of healthcare, so all of us in this room will experience one major diagnostic error in our lifetime. That's pretty bad. And Johns Hopkins came up with this study. It's a really good study if you think about it. 35 million admissions they evaluated in their own property, in their own system. And they found out that nearly 10% of the deaths were medical related, 10%. So kind of going back to saying, what does AI do for us, right, today? How can we use it to improve systems? Just to make sure that we kind of understand a little bit on the tools and the toys that we see on the vendor booths and on the floor here today, is that we need to ask what is accuracy and what is precision. The medical school Part 1 exam was taken by an AI platform with 85% accuracy. Basically passed the exam with 85%. Just AI. And this is 2 years ago. So it's probably even much, much better now. So it's very accurate. So what is the difference between accuracy and precision? Tonight after your cocktails, if there was a dartboard, you had a little too many, where would those darts go? Anywhere. You might hit it, or you may just go anywhere on the board, right? So that's random. So these darts are random. This, if you see in the right lower corner, they're all honed in on one place, all the darts. So that means you could get a spot every time, and it's reproducible. You just know, I gotta go somewhere, and you reproduce it. You want to get to the center, your goal, but you go off center, but you get it there every time. That's what we do in healthcare. In healthcare, we're precise. We are scientists by heart. So we basically want to say, I want to reproduce that experiment in Alaska. So I want to make sure it does the same thing every time. That's precision. Now, look at this. This is not necessarily getting the target, but it's coming really close to the target. This is what a basketball player or athlete does. They are accurate. So a basketball player is going to hit the rim, this side, backward, wherever, but it'll go into the basket. So that's accuracy, and so it could hit anywhere. But the physicians, clinicians, healthcare are very precise. So that's kind of the difference between two. So if we were to look at this and look at an AI tool that you want to implement, you need to kind of look and say, is it precise, is it accurate, and what percentage? So if you were to put this on a Y and X axis and find out where would that first board go, after 2 cocktails, it's the left lower quadrant, right? It's not precise, not accurate. Then the healthcare system is precise, so it goes on the very high precision but low accuracy. And the athlete, of course, is high accuracy, low precision. So where do you really want to be? What will AI do? If you had something that you want to invest in, where do you want to see in this quadrant? Right? You want high accuracy, high precision, and that's what AI can get. That's what that CT scanner was. 99% accurate in the diagnosis. It's precise, it's accurate, it's timely, all of the above. So this is what you ultimately want, everything to strike right in the middle. So if you were to say, what examples can you think of today that falls into this? Every time it's a slam dunk, every time it's a target's hit without failure, where do you think? What example can you give your kids tomorrow? That's 100% accurate, 100% precise, every time, no flaw. Blue angels, how many are there in this? Not a trick question. How many birds do you see? How many do you see? 4? 4? It's actually 6. Look at this. How many do you see? 1? This is precise. This is accurate, right? I mean, if you think about it, these guys don't have play room at all. I mean, they are like literally between the helmet and the bottom of the other aircraft. You know what the distance is? 5 feet, 10 feet, 20 feet? What do you think? 20 feet? 18 inches. 18 inches. Can you imagine if someone sneezed, coughed, messed up? That would be bad news for all 6 or all the pilots. So this is where you need to be. This is what AI is going to do to help us get there. And they're doing it already. So when you start looking at things to improve, you need to start asking the vendors hard questions, right? This is a 51-year-old gentleman that I saw about 2 years ago on a Sunday, 2 o'clock, lights and siren, EMS comes in, acute STEMI. The EKG had changes, EMS saw them, noticed them, said, hey, this looks like a heart attack, we're coming in, lights and siren, they're in the door. We do all the things. I mean, everything went by the books. even better than by the books. The patient went to the cath lab on a Sunday, cardiologist, they opened him up within 30 minutes and got him in the ICU. He was resting, chilling. Monday morning, I go back to work and I get all these, text messages and emails saying, what a great job you guys did last night or yesterday afternoon on a Sunday. I'm like, wow, my head's gloating. Like all the people are coming down and saying, oh, you guys did a great job. Then I was thinking on the drive home, are we rewarding the wrong habits? Are we rewarding somebody that comes in and we do all of these process and protocol to get the person in cath lab, or should we be rewarding the one that sits down with this patient 10 years ago and says, hey, buddy, I know what road you're on. You're hypertensive, you're a little obese, you got high lipidemia, you're a smoker, I know what road this is. I can get you off and get you on a detour and get you feeling better. That should have happened 10 years ago. It didn't. Needless to say, my question to this guy was, he was in the cath lab, had a stent put in 3 years ago, so why did he come back? Anybody? Why do you think he came back in 3 years and the stent occluded? What do you think? Non-compliance? He still smokes? He still doesn't take his meds? What do you think? All of the above? But, he was really a solid citizen. He stopped smoking. He was truly a solid citizen. He did all the right things. But the Plavix he was on, everyone heard about Plavix, right? Okay. So Plavix that most of the people get put on after a stent, 30% of people in this audience right now cannot take Plavix. If they do take Plavix, it's sugar pills. 30% of us. So this gentleman did not have the enzyme to break it down, and he couldn't break the Plavix, so he was basically taking no Plavix. But he was taking it every day. So the question becomes that this enzyme that we're talking about, this is Plavix. The Plavix needs this particular enzyme in the liver. If not, then it doesn't make it active. You can take the Plavix, in order to become active, this enzyme needs to get together, it becomes active. Then it works. If you don't have the enzyme, out of luck. So had we done this genetic test, it's available. Had we done this genetic test, we could have had option B, right? We could have had this patient on something else. But we never did this test. University of Colorado has actually put an AI together to go through all of their patients in the practice, primary care, family, cardiology, all the practice, and say, who's on Plavix? Let's pull them out. Do they have this genetic testing? If not, why not? If not, let's bring them in. Let's alert them. They have a system in place. They have, let's say, 20 steps. It's driven by AI. Why can you and I not do this on an Excel? We could. It's time consuming, and there's an error rate. When AI does it, the error rate almost approaches zero. So now you can go through thousands of records and not miss that one and have confidence. I want something that is 99% accurate. So if I didn't tell you that I have a 99% accurate algorithm, workflow, you're probably going to reject it. Because you have to make it right, otherwise you don't start something you can't do it right. So this is methotrexate. Same story. Methotrexate, 20% of the patients taking methotrexate are basically taking sugar pill and getting the toxicity, but not the benefits. Methotrexate, right? And for rheumatoid, I think most of you are, it's a lot of the younger population take it, a lot of the older population take it. It's got toxicity. If you had 20-25% resistance to it, why take it without doing the test? And the genetic test is available. It's like $80. The cost of the test is not the factor here. The factor is, can you do it with efficiency and make sure that it's like safe and don't have any fallouts? Then your institution will adopt it. This is 5-HU. Story goes on. Another genetic test you can do, it's about $160 on the street. You can get it for $160. Hospitals probably can get it for $20. I'm not sure, but it's not like a $10,000 test. That's the point. It's $160 if you just go to LabCorp right now, give them blood. They'll do this test, 5-FU. It's for prostate cancer. So why give a patient toxicity of this drug when you could do a $160 test? So again, This is how we defined personalized medicine, custom tailored to you, to your patients. And that's why I was saying MedPalm 2 that Mayo Clinic residents use is actually custom tailoring medicine to that patient. The next evolution of healthcare is going to be how do we personalize specific to that patient. So going back to saying that for the CFOs and CEOs in the room, unless you have an algorithm that is not close to a zero error rate, you're probably not want to implementing this. So what I always say, what are you doing in your zip code, right? Let's say this is your little map and your little zip code, your community. What can you do in your community? You can really stand out because you may not be tied with the bigger system. To implement this in a bigger system like University of Colorado, it's like it's moving the Titanic. But in the smaller systems, you can implement this by having a dialogue with some of your senior medical staff and put some of these things in place and literally do the right medicine in a smaller community hospital. It's impressive. We, for years, have been collecting data. Remember 25 years ago, CMS, everybody said, hey, we're not going to pay you unless you do electronic digital records. And it was just, every year we get extensions on all of this. And we've got so much information, only 5% of the data that we have collected, we actually use. So 95% of the data nearly just sitting in some warehouse collecting dust, but it's there. So moving forward, that data collection, there were some smart people 20 years ago recognizing that the data that we're collecting 20 years ago will be useful one day. And that one day is now. So we harvested data. How are we going to use this? We've talked about meaningful use. So meaningful use of this information today would be, I just put something simple, appendicitis, right? If you took a room full of senior doctors, senior surgeons in this room, 300 senior surgeons in this room, and you ask them about appendicitis, what's the signs and symptoms? With my 200 patients, they have this. This gentleman says, with my 100 patients, my lifetime experience with appendicitis, they have this. So you have 300 senior surgeons with a lot of data. But what if you collected these 300 surgeons' patients and made it into 1 million, 10 million, 100 million records? Now you have some meaningful answers. This surgeon says, high fever. What does high fever mean? 101 or 101.5? What is high fever? But the data will show you that fever above 101.5 is meaningful, below that it's not meaningful. It gives you a scoring system. So MD-Cal is a manual algorithm. With AI, it's totally changed. Instead of having 20 variables, AI can look at 300 variables and say that because of these 300 variables we found in your patient, yes, no, yes, no, yes, no, yes, no, the likelihood of appendicitis is now 85%. Can you imagine feeding that information before they come to the ER? Moms can do this at home. Mom can Google this right now on internet and do this and call the family doc and say, hey, I did MD-Cal and he scores 80%. I don't want to come to you. I want to go to get a CT and go to the ER. I mean, you can do that now, today. So the point is, with more data, you can, if you have the right algorithms, you can process that data into something more meaningful. And comes into what we call predictive modeling, is really, if you think about it, who wants this information? Health insurance, life insurance? I mean, can you imagine having all this information on one of us, and then you apply for life insurance? And you go in and they put your data in because they have the information and they say, no, we're not going to give you life insurance. It's their discretion to say no because they find out that your lifespan is not good, right? But just because of data collected. So really this information is, everyone is looking for this, right? If you think about it. This was in a publication about 2 years ago, American Academy of Family Physicians. It basically talked about who owns the medical records. Any of these clinical EMRs are awesome, but they sit on an island. They actually sit on an island. If you are in this hospital and you want to get a CAT scan, you had an MRI done here 10 days ago, good luck trying to get that CAT scan or MRI or EKG transmitted here, right? Best of luck, and we know this. So who owns the medical records? System does, we don't, patients don't, but who should own them? Patients, the soldiers. In the wars, what happened? If I was a soldier, I went to this medic or they jot down notes, what happened, and they roll it up and give it back to the soldier. Soldier puts it in the backpack, on he goes. He gets in trouble 2 months later at another post. He goes there, he pulls it out and says, here's my records. If you think about it, we need to resort back to this. This is the best medical record system available if patients can control it, right? If you think about it, it needs to be in the hands of the patient. We got to put it back where it belongs, because a patient then can take those records and go anywhere, any system. We're not holding them hostage anymore. No system will hold them as hostage. They can go to anywhere, have all the records together. There's a handful of vendors that actually allow patients to carry their own portal, and they pull data from every resource, and it's very, very impressive. Systems out there that are available. So why am I telling you this? The depth of the data that's available allows predictive modeling, we said. You can custom tailor the care. You can personalize the medicine. Who wants it? Everybody wants it. Life insurance, health insurance, everybody wants it. You should want it as the CEO of the hospital. You want the data for your community. What's happening in your population health. And who owns it? Patients should own it. In your market, for the CEO here and others, what can you do? Why is this important? What if you took this platform and engaged every patient when they came in for outpatient surgery, exited the ER at discharge. At the time of discharge, you give it to the discharge planner, and you put this app on their phone. You white label it to your name of the hospital. So when I'm in the community 3 months later, and gosh, I got this cough, I want to go see somebody, I don't have a primary care, you have a button resort, like, okay, click here, we'll get you in tomorrow morning. Or someone says you got to get an X-ray, or something more complicated. Someone says you got to get an MRI, and the neighbor's saying, "Oh, when I had that kind of knee pain, I got my doctor to do an MRI. Maybe you should get one." So you can actually talk to a nurse on the app and say, "Do I need an MRI? If so, where do I go?" Why have them drive 50 miles away? Because the neighbor is going to say, "I went to that university hospital 50 miles away, and they did this cool MRI." If your place can do an MRI, why not keep that patient local? And if you can engage those patients on the way out of your wall of the building, then they will be sort of contained in that market. And there's a lot more you could do with this, but the idea is, how can you give and empower the patient and they come right back knocking on your door? Why should they go 50 miles away? You could do an ultrasound, cardiac ultrasound. You may not have a cardiologist, but you have a virtual cardiologist, right? Well, if you have a virtual cardiologist and they can make an appointment next Monday at 2 o'clock, they're not going to drive 50 miles. And then, by the way, they can get an echo on Friday before they see the cardiologist, so they have it. It works. Screening tools. So I was told, and you can correct me, that the screening tools, when I was a medical school and resident and years after, is like to save lives. And once we do the screen mammogram or cervical cultures, we can make sure that we can diagnose cancer early. Colonoscopies, PSA, digital rectal exam, all these were screening tools. Diagnose early, save life. But I was disappointed that's not true. Screening tools are nothing more than economic price on life. That's what it is. It's putting a price on life to say, if we diagnose this early, is it going to save us money in the healthcare system because we can treat it early, right? If you diagnose cervical cancer early, then it's really very minimal treatment cost. If you diagnose it late, there's a lot of treatment cost, so let's diagnose it early. That's the logic. It's putting a price on life. So what is this based on? At age 50, you should get a colonoscopy. Recent data says 45. Who came up with that?
USPTF,
Okay.
Task Force.
So it's some body sat down and said, we're going to do it at age 50. Now they're saying age 45. It's based on what? 350 million Americans. That's what it's based on. But you have one patient. How do you personalize this to your patient, that patient? That patient may need a colonoscopy at age 30 or maybe at 70. So if you know and personalize this, then you can actually minimize overuse, misuse, abuse of dollars, right? So you don't, so basically colonoscopies can be, if you put all the risk factors, why did it go from, it used to be 55, then 50, now even 45, based on risk factors. So those risk factors are identified by some data collection, okay? There's like 5, 10 risk factors. But I'm saying to you that instead of these 5, 10 risk factors, what if you had 500 risk factors? You and I couldn't process that. It's not possible. But if you could find where they were born, where they lived, what diet, all of these things, put them in. And if you had 2,000 pages of medical records on a 50-year-old, you'll have that data. And that information will say, this person should get a colonoscopy age 65 because they're super low risk. Or this person age 40, they're high risk. And insurance companies will then pre-authorize that. Try to get a pre-authorization for colonoscopy screening for a 35-year-old. It's impossible. With AI, they'll say, look, to the United, based on this, United, just do it. There's actual data. So now you're not holding on the phone for 3 hours trying to get that approved. Because United says, okay, I got it. This is all working. So the question is, how will we do colonoscopies in your community, in your zip code, 10 years from now? It's going to be very different. Very different. So I will tell you that Mount Sinai has a very impressive AI tool they put together. And these are not proprietary, these are not secret. People are using it, it's working, you find out what's working, they'll be more than happy to entertain you, right? I mean, if you think about it. Medicine is very open. We may compete, but at the same time, medicine is really driven by heart. If you think about it, if my pharmacy was out of a drug and a competing hospital 5 miles away had that drug, my security guy will go pick it up or their security guy will deliver it. I mean, we may compete in some form or fashion, but at the end of the day, patient care, we all kind of come together. So all these tools that other people are using are available to you and me. So Mount Sinai has figured this out and said they have actually shown an impact on screening colonoscopies, and the insurance companies or payers are actually complying with their data. I think it's pretty impressive. Okay, this is 2025. 5 years from now, it's going to change. But when I put this, what's going to happen, say 10 years from now, it's just my guess. I don't know what's going to happen in 10 years. But I can tell you one thing that's going to happen in the future is we're going to have a zip code or a community population health is going to be redefined. You're going to have a payer, I'll just pick on some United, let's say, a payer. They'll drop a bag in your town and say, here's a bag of X amount of dollars. You figure it out in your community how you're going to manage colon cancer. Now it's in your hands to say, how do I embrace my community to use these dollars wisely to screen appropriately so we don't misuse these dollars. It will take a payer to come and drop a bag and force you to say, if you want to take care of my patients, here's X dollars, take care of them. And you'll say, I can't, you got to give me more. They said, that's all I got. Then you're going to have to scramble and try to figure out how to do it. And this is just one example. And my next example is PSA. Why did I pick PSA as my next example? We're not going to talk about it. I'll tell you why. Biden. Remember what happened recently? He was diagnosed with prostate cancer because they stopped screening at a certain age. Why? 350 million Americans, urologists say, and after age, I think 70, you don't need to do PSAs. So they get one, but he got prostate cancer. So obviously he's a political figure, so it's in the news. But the point is, if we had the right data, maybe for him, it would have said, you continue screening, he's at high risk. So again, going back to saying when they impact population health, your payers, it's going to change the paradigm on how we screen, how we view our communities. And when I say communities, I mean if Medicare came to you and said, if you want to grab these people, patients in your network, then this is what we're gonna offer you, right? And that's what's gonna change. This is a 62-year-old, weakness, right-sided, total weakness. My security guard is saying what? Stroke. The EMS brings him in, stroke. Okay, so everyone knows it's stroke, possible stroke. All right, so this patient really gets into the CAT scanner. I mean, boom, 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 everything's happening. It's amazing, all right? Everything's smooth, everything, CT gets done, there's no bleed, and no evidence of bleed. This is AI, so it just told you right off the bat, no bleed, boom, got it. Now it's 2 a.m. We don't need to wake up a radiologist, remember? Because it's 99% accurate. Why wake up the urologist? Let the the radiologist, let them sleep and let them come at 8 because there's a shortage in town. So why waste their time doing stuff that we can figure out on our own? No bleed. So now, okay, you're gonna start thrombolytics. Did it meet the guidelines? Did it meet the window? All the players that are involved in the care of this patient, from the neurologist that's on Zoom, radiology tech, the AI is always ready. They're not ever going to call in strike. They're always there. And so everybody that's taking care of this patient, your iPhones or phones are working and everybody's in sync. All of this is improving systems, right? If you think about it, it's improving system. It's high reliability organization, but it's really a high reliability process for stroke. Right? If we can't fix the entire hospital, but we can fix different parts of the hospital, you fix majority parts, you're going to get a really high reliability hospital. So this is proven that about 75% more efficient from the scanner to the team, from the team to the treatment. I mean, it's like magic. It's amazing. It's working. This is a project that's been out for 2 years. The system's available. It's all AI driven. Everybody's in sync. So really what's happening? You get how many of you guys stroke centers? Maybe your neighboring hospitals, the bigger hospitals are probably stroke centers, right? So when the EMS is coming in with licensed RN with that 62-year-old with right-sided hemiparesis, are they coming to your community hospital or are they going to the bigger hospital down the road? They're going to the neighboring hospital where they have a stroke center. But if you can show them that you have in-house tools that can expedite, they should be coming to you. And you can give the same or better care instead of them driving another 45 minutes or 40 minutes north. And this is what I'm meaning by same or better care. You are a small, I'm not saying small is good sometimes, because now you have an organization that you can change quickly rather than having a 100-bed ER that you can't change quickly. Sometimes the size of the organization makes an impact how quickly you can get them to shift. And so, again, going back to saying, you can't change the entire hospital overnight or your clinic or your health system, but you could make changes in the different parts, and eventually all the parts will talk and you get something meaningful. So again, going back to saying stroke centers, or are they coming to you? Are they going to your competition up north, or can they stop and see you? Really, they can come and see you. They truly can, because you can deliver better care. Because if they needed a mechanical thrombectomy, you have 24 hours. If they need thrombolytics, you have 3.5 hours. That 45 minutes will make a big difference if they're going to drive somewhere, right? And if you can squeeze that time from getting the CT, red, team, drug, and squeeze that time down to 30 minutes and make it more efficient, like these guys are doing, 72% and 50%, that's powerful. That actually is very powerful. So FDA has about 430 algorithms right now on their table that they're looking at for approval. They're seeking approval. 400 plus. It's every week there's something coming out, and some institutions are implementing and using it. So, last week I was in Boston at a cocktail party, and some of the folks, they say, our healthcare system is broken, and, the guys at this table, I'm saying, guys, if the healthcare system was broken, like the glass is broken, we cannot put it back together. It's broke. Our healthcare system, think about it, it's not broken. We have the best radiology tools, best orthopods, the best prosthesis, cancer drugs, antibodies, you name it. We have the best money can ever buy in the world. We have all the raw ingredients. We also have amazing protocols. People from across the world come to MD Anderson to get their cancer treatment protocol, right? So we have all the raw ingredients. We have all the amazing protocols. Yet we can't deliver the right care every time to the right, no matter what. It's like McDonald's French fries, right? You get the same fries no matter where you go. We're stuck in the delivery mode. We have all the raw ingredients, we have all the algorithms, we just gotta get it right every time for that patient. So I'll leave you with this thought, and then we'll open it up for questions.
Maverick. 30 plus years of service. Combat medals. Citations. Only man to shoot down 3 enemy planes in the last 40 years. Distinguished. 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 Yet you can't get a promotion, you won't retire, and despite your best efforts, you refuse to die. You should be at least a 2-star admiral by now, if not a senator. Yet here you are. Captain. Why is that?
It's one of life's mysteries, sir.
This isn't a joke. I asked you a question.
I'm where I belong, sir.
Well, the Navy doesn't see it that way. Not anymore. These planes you've been testing, Captain, one day, sooner than later, they won't need pilots at all. Pilots that need to sleep, eat, take a piss. Pilots that disobey orders. All you did was buy some time for those men out there. The future is coming, and you're not in it. The end is inevitable, Maverick. Your kind is headed for extinction.
If you think about this, what was their mission? It's been the same for 100 years. Shoot down enemy planes. But today we're going to use drones. We're going to use technology. We're not going to use pilots. If you think about it, this is really where we're at, right? Our ultimate goal is to deliver safe care and establish a high reliability organization or department to minimize medical errors. Mission has not changed. I think that method is changing. We need to evolve with the methods. For these guys, for 100 years, they've been doing the same thing, shoot down enemy planes. How we do it is a question.